Thank you very much. For those of you who might have joined us a little bit later online, again, my name is Malte Gerold, Director of Innovation and Improvement at the Health Foundation. So we heard a lot about priorities for a strategy on AI in the NHS. We had our panel discussion on that. We had the perspective of the Minister and just the discussion about the implications for the NHS workforce and making it work for them. Now, we've got one more fantastic speaker and presentation for you, because while we've just been talking mostly about the issues that are going to be relevant over the next 2-3 years for how we make reality the benefits of AI, the development of AI is not going to stand still at all, and particularly with the development of large language models and generative AI is only going to pick up pace. And that really raises the question, how should we be starting to think today about where AI might be in 3 to 5 years or 7 years, and what might be some of the decisions and considerations we might have to start tackling today to be in the best possible place with the NHS and in the UK to make reality and get the benefits out of that. Now, to help us address this question, we've got with us Dr. Isaac Zach-Kohane, who is the chair of the Department of Biomedical Informatics at the Harvard Medical School. And we were agile this morning with our timetable, and we are now digital this afternoon because Zach is joining us from Harvard. Good morning, Zach. Thank you so much for joining us. Fantastic.
Be here.
Zach is going to talk to us for about 20 minutes on the screen, and then we'll take some questions. So again, please use Slido, and while Zach is speaking, feel free to put your questions through, and we will put them to Zach a bit later. Zach, thank you again for joining us, and over to you.
Thank you very much. It's a privilege to be with you on this. And let's see, first of all, if I can go through the first challenge, which is to actually share my screen. Let's see. Okay, PowerPoint, share. Are you seeing the right screen, the correct screen?
Yes.
Perfect. All right, everybody. So I will try to get this done in 20 minutes. I'm going to be, I think, provocative, but not needlessly so. I think it's important for us all to get out of our bubble and to consider some of the larger issues. So I'm going to try to bring to you my perspective from someone who both trained in medicine and pediatric endocrinology, but I also have a PhD in computer science back from the 1980s, where I worked on artificial intelligence and have since. So these are very exciting times. And without further ado, let's go into it. So I am going to perhaps over-dramatize from some of your perspectives, but I believe this is actually correct, that we are in the context of a healthcare system under siege that is having its foundations challenged and that are shaky. And in that context, we have to understand that AI and medicine is moving both faster and slower than you think, and I will elaborate upon that. And that AI transforms the meaning of patient-centered healthcare from a pious aspiration to a very concrete, potentially institutionally threatening movement. And we have to understand AI medicine not vis-a-vis what we believe our healthcare system should be, but in what it is today, which is the growing gap. But the cup half full version is this is a generational opportunity to reimagine clinical care. There are many concerns that we should have, and we do have, but I'm going to perhaps spend the most time of the remaining 19 minutes talking about how the concern about our values and how to inject that into AI. And then I will close with a few key questions that require prompt attention or else. By the way, you may be seeing a QR code on the screen. That's just to entertain me. If you go to it and stop listening to me, you can answer 2 questions, which I'll get back to towards the end, and we'll see, or not, and we'll see what that entails. So AI is moving faster than we think. I'm sure all of you have seen this version of this slide, this graph, which basically summarizes how we went from these large language models not being able to compete with a single human being on medical examinations in the United States, the so-called Step 1 United States medical licensing exam, to within 3 years being better than 80 to 90% of doctors. And not just one company's large language model, both Google's and OpenAI/Microsoft's. And that was only 3 years. And we have not stopped this acceleration. It's very important, and I think there's a huge advantage here for the UK in that performance scales with data. That is, the two most successful parts, the keys to success of these large language models, of these generative models, has been the growth in both the size of the models, how many parameters they have, but also how much data they have. And I think this is dramatically illustrated in this graph where we see just a mere 4 years ago, there was a paper in Nature that used a multimodal generative model to link the text of echocardiogram reports to the video, to the pictures in the echocardiogram. And there was only 10,000 images, and the performance was not good. Just by going from 10,000, 10 to the 4, to 10 to the 6, a million echoes paired with the reports. Recently published, this EchoClip investigation done by cardiologists shows that in real time you can have these images from an echocardiogram, not done by a doctor, just by an echocardiographer technician, interpreted at the level of an expert cardiologist. And that's just because we're increased the scale of the data once we have the transformer model. The UK is in an interesting position if you can get your politics sorted out correctly, institutional politics, so that you can share data at scale. You're in great shape to work with the scale up. Many argue that it is merely, these programs are merely somehow retrieving back old data. Here's a picture that I knew for a fact. I'm on the editorial board of New England Journal of Medicine, and I'm editor-in-chief of NEJM AI, a new spin-off journal. And this was an image that was made available just a few months ago. And when it just came out, I asked GPT-4, what is this picture? And I gave it details that were given to all readers of NEJM, that there was a 70-year-old man presenting with a 2-day history of an itchy rash. I removed one very important information that the human readers had. Nonetheless, in coming up with its differential diagnosis, it included bleomycin toxicity, but it also included something I had never heard of, shiitake mushroom dermatitis. And sure enough, what I had elided from the report is this individual had eaten mushrooms the day before the onset of a rash, and this was in fact shiitake mushroom dermatitis. How many primary care doctors do you know will make this diagnosis? So we've heard today, I was able to hear the last panel about a lot of the problems, and there certainly are many problems. There are problems such as we heard about hallucinations. I'm going to briefly touch on, and so I won't go further on that, but there are problems around data set shift, which are enormously important, and I'll get to problems in authoritativeness or values or bias. Back in the middle of COVID, the electronic health record vendor, Epic, put out a predictor of when we really thought we were going to run out of ICU beds, a predictor of who was likely to deteriorate and would require ICU and intubation. And they deployed this in several hospitals that used the Epic system. But at the same time, other hospitals with the same electronic health record vendor, Epic, employing this, showed that At the same time, this was poorly calibrated. In plain English, it was not predicting correctly or even in the right order the patients most likely to deteriorate. And why was that? Because it was a different hospital, different patient mix, different styles of practicing medicine, and therefore what had been learned in one set of hospitals did not transfer well to another. That's data set shift. Even more importantly, 6 months later, many hospitals, including the original hospitals where a program was turned on, turned off the program because medicine had changed and the virus had changed. But most importantly, medicine had changed. Thanks to the great work done in the UK, we were treating everybody who was very sick with dexamethasone, for example, but many other things had changed. And so the predictions were completely off. And this is not just a one-off example. Medicine is always changing and is frequently local. And so trying to validate these in a universal way as we do for drugs, for medications, it's just not going to work. Going to values. This article that we recently published in the New England Journal of Medicine talks about values and how these are injected in medicine. You have heard a lot about how the training data may influence the values. You may have heard about how we construct our models, how that influences the values. But we have not talked enough about this, which is the very explicit alignment or steering using a variety of technical approaches that I won't bore you with, but I'll just shout out the names like reinforcement learning with human feedback or fine-tuning, or just in-context learning. The explicit steering of these models is underappreciated, and it's mostly done these days to avoid these large language models, to say something that was impolitic, that would embarrass someone, that might be racist. But the values of our healthcare system are either buried in that steering or not addressed. And it's very, very important. So today, we asked in this publication I just told you about, we give a case of a 14-year-old male who's short in the 10th percentile for age and has a middling response to growth hormone level stimulation. And we gave several roles to GPT-4 and asked it what it was recommending. And if we said it was a pediatric endocrinologist, it says, given the above circumstances, blah, 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 early intervention is critical to maximizing the efficacy of the treatment and improving long-term health. And so I strongly recommend initiating growth hormone. If you tell it that it is an insurance company representative, it says, this is the same model. After careful review of the medical documentation provided, including blah, 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 we have assessed blah, blah, blah. This level does not typically indicate a deficiency that would necessitate growth hormone therapy. This is much more important than bias. How are we going to steer these systems? What values are we going to give to them? Even looking at the simple case, who is the next patient we're going to see? I understand in the UK, we have long waiting lines for primary care, as we do in the United States. Who are we going to see next if you have a full panel of patients to be seen the next day? And who is doing the steering? We're not hearing a lot of discussion about this, but this is exactly our responsibility as medical professionals, as policymakers, and as patients driving policy. Speaking of policy, the US government has waded into this, and President Biden put out an executive order back a year ago, which has been very important in essentially notifying all the agencies that they better wake up, identify chief AI officers, look at their various systems to see how they might be impacted by AI. But it's pretty generic by necessity, because it's not going to give a lot of details about what's required in medicine, and consequently, it leaves the door open to, and in fact, as a call for other efforts. Meanwhile, in this article that we published in NEJMAI, I think which was a review of how academic medical centers are dealing with these programs. I love this quote from their study. Well, nothing's been regulated to date, really. Our regulatory framework is very challenging. And the vendor markets a model, and the R squared is 0.09. It says that it says that in the model brief. But unless you have people who already understand biostatistics, read that small fine print, they're literally marketing that. But people don't know that means the model doesn't do anything for you. So I think that's very much where we are. And if you look at the United States, there are over 600 approvals of AI widgets as a software as a medical device. And as shown in this illustration that I obtained from this recent preprint, most of these AI devices are only tested in one single academic health center or one single health center. So the data shifts issues are huge, and these studies are typically not focused on benefit to patients. They're about some technical threshold. And so we're really going into terra incognita here, and our current regulatory apparatus is woefully inadequate. As a result, even though there are projects such as the CHAI initiative in the United States, for example, many academic health centers who are leaders in the implementing of AI have voiced concerns that we should actually not just be having these sort of compliance conformance testing, but we need to actually have evaluations of clinical effectiveness. And our colleagues here at UCSD and throughout the United States who authored this article, I think make a very persuasive case for beyond regulation, we really need to have systematic clinical effectiveness. One of our colleagues, David Blumenthal, who not only is a professor at Harvard Medical School, but was in the Obama administration during the implementation of EHRs, and was formerly the president of the Commonwealth Fund. He wrote a very nice article with Baku Patel from Google, arguing that we really should start thinking more about validating these widgets, these large language models, much more akin to the way we validate humans, not just whether they can, we should make sure that they're trained on the right information, that they get passing grades on relevant clinical exams, but have supervised use in which outputs and recommendations are reviewed and are regularly updated and report periodically to regulatory authorities. So this, I believe, is the true engagement that we're going to have, and just a bunch of pointy-headed professionals sitting around a nice conference table in my hometown in Geneva, Switzerland, is not going to do the trick. Also, we better pay attention to the patient perspective. Here is a remarkably prismatic example. I was fortunate to meet this individual. He was a young, healthy individual who started having problems walking, problems chewing, intractable pain that would leave him prostrate for days and missing school, to the point, after visiting 17 doctors, and all these imaging studies, MRIs, you name it, did what the healthcare system typically does when we run out of solutions. They say, perhaps you should see a psychiatrist. Instead, the mother took all the clinical documentation, not the images, all the clinical documentation she could find that had been given to her, and basically typed it into GPT-4. And GPT-4 said, well, I'm not a doctor, but probably the top of the differential diagnosis is tethered cord syndrome. Tethered cord is when your spinal cord, the sort of ponytail end of it gets trapped in the bones of your spine. And so she went to a doctor in Michigan, so happens a Harvard-trained neurosurgeon, who then looked at the MRI that had been taken a while ago, looked at it and said, yep, it's pelvic cord syndrome. Then did the surgery, and the child who I met is delightful and is so much better. What happened, happens all the time in medicine, the original MRI was misread, and then everybody referred back to the report. They referred back to the report and not to the image. And so, like in a bad telephone game, truth was not propagated. But even though GPT-4 did not have access to the image, it just said preponderance of evidence about this case suggests that. And do we think this is a rare occurrence in medicine? No, it is not a rare occurrence. And that is exactly why a much more questionable product, search, as in Google search, as in Dr. Google, is used all the time. Why? Because as a healthcare system, we neither have the time, the ability to have extended conversations, or to give thoughtful second opinions. And consumers are going to use this more and more in this mode without any other regulatory oversight for the obvious reasons. All right. And in that perspective, and here I'm giving you a path which is going to be potentially going to be interesting. I happen to have a lot of confidence in it, but it may end up not being the path forward. But for a variety of reasons, I and my colleagues were very involved in writing APIs, application programming interface, to electronic health records. And this started in 2009 with the emergence of electronic health records. But and we built this API so that apps could be built on top of EHRs. But of course, as is usually the case, unexpected things happened. And what happened is Apple took our API and implemented on Apple Health so that throughout the United States, in over 800 hospitals, reaching over 50 million patients, you have an Apple Health, your labs, your medications, your diagnoses, your procedures, demographics, and vital signs, and medications in case I didn't say it, all available programmatically in storage. You can view it as a consumer as a nice graphic, but it's programmatically in your app. And we've done this, as I showed here, as just a proof of concept. We wrote an app that if you consent to this app having access to your data, it will evaluate your cholesterol level, see if you fit a guideline, see if you're already on cholesterol lowering medications, if your cholesterol exceeds, and will give you a PDF that you can give your doctor and say, maybe we should consider starting me on a statin. And we're not the only ones thinking about this. The UK, with the app from the NIH, is thinking exactly about this kind of consumer-facing empowerment. But currently, it's not quite there yet. And in a recent report in the House of Commons on the digital transformation in the NHS, witnesses agreed that current integration of the app with NHS services is limited. But you have an amazing opportunity because you have a rich health data infrastructure, and you could really address some of the needs of patients today in that fashion. And what are the needs? Those needs are happening in the context of a workforce shortage. Shown on the left is a report from the American Academy of Medical Colleges showing that within a very short 10-year span, we're going to be missing somewhere between 37,000 and 125,000 primary care doctors. And this is true too in the UK. There's going to be a huge shortfall, and frankly, whenever I go to any medical school, very few doctors want to go into primary care, and those who are in are figuring out how to go out. And so what is the 5-year challenge from that perspective? In the United States is, can we take our very smart but not medical school trained health professionals like nurse practitioners and physician assistants, or in the UK, the nurses, the midwives, the dual registrants, the physician assistants, and can we add AI to them to actually provide the size of workforce they would have to actually give timely care, not to wait 3 months, but to wait 3 days before your next visit with a health professional who both is a human in the loop, but also augmented by the AI. Problem, of course, is the establishment is going to fight back. And I just saw here that the BMA is urging NHS England to immediately halt the expansion of PAs, which in my opinion is sad because PAs are terrific practitioners, and augmented AI, I would wager they do at least as well as primary care MDs. We're nonetheless going to have to study how doctors and AI mixes. There are a number of studies coming out, one of which I'm showing here, which suggests that in certain contexts, doctors are worse with AI, or stated differently, that sometimes the AI is worse with the doctor. And so what are the right combinations for what tasks, I think, remains to be determined. And so I think our 10-year goal should be, in looking at the physician-clinician-patient relationship, how are we going to use the traditional sources of information that leads doctors and clinicians to their decision-making, and augmented, as shown by the icon at the top of the screen, by AI. But how do we use that information and complement it with another set of tools that are going to be directly interacting with patients or their representatives, such as a pharmacy or a health coach, or your coworkers or colleagues, or an AI who directly coaches you and your family. This ecosystem is a system that is much more scalable than unrealistic plans for just expanding a workforce that will never expand to where we need it to be. So in closing, what are my selected urgent questions for you? How will we ensure that citizens benefit from AI applications? Because I know we worry a lot, but given the gap in healthcare today, how can we make sure AI is going to benefit them? And where and how will NHS inject societal and patient values? I hope you heard me when I was talking about steering. This is probably the most important place that we should be asking questions. Who is this AI serving? I see very little leadership, very little agency in the healthcare system to take this on. And in which clinical context? I think we have to consider, what are the clinical contexts where we evaluate AI models? Is it always going to be in the hospital? Is it going to be in a very new kind of context? And what are we comparing these to? If we compare AI plus a nurse practitioner against medicine as we think it should be practiced, as opposed to the way it actually is practiced, we'll be making the wrong evaluations. And with that, I'll thank you, and I'm glad to take questions.
Thank you so much, Zach. Zach, thank you very much for the presentation and your closing challenges as well. I wanted to start with one question that relates back to what we heard earlier in the day. We heard about the risk of inequality in AI bias itself, or the data sets. We heard about the risk of AI aristocracy, where some organizations are much better at doing AI than others. I think there's a similar risk about some countries being much more advanced than others. Now, with your reference to values and who decides what the values are of AI in the future, it feels like there is a further potential inequality there, which is that we may end up with medical AI approaches that differ simply because they are emerging in different countries with different values being sort of infused in that. Is that a risk? Is that actually no different from today because different medical communities have slightly different approaches? Or is that something we should try and address collaboratively across countries?
Well, first of all, it may be that there are genuinely different value systems in different countries, and that they're, from the perspective of those countries, they're substantive. And the way those differences get expressed is that the medical societies of those countries ultimately decide how to work up someone with a risk of breast cancer, or how to treat with growth hormone. And so one version of this, which would be, I think, dystopian, is we'd have one AI to rule them all, in which case we would say everybody's values have to be the same. But I think a more constructive future is different healthcare systems leaders and policymakers should say, what are the values of our healthcare system that we hew to? And how do we inject those into the AIs and this can be on the same so-called pre-trained model, the thing that is the model that's trained with all the data, but afterwards in the alignment, I think that is in fact a local question, local in the sense of national question. Now, as in many things in computing, by having that conversation, you actually surface values which may actually not be the right values. It might be that there's certain American doctors who are worrying more about their wallet than about their patient, and maybe having an international discussion about what the values are may cause bubbling up of values that are more truly representative of our societies. But nonetheless, we need to have that conversation. And with regard to inequalities, I am much more concerned, frankly, with inequalities in our current healthcare system. In whether you're in a communist system or in the UK or in the United States, the better connected you are, the higher you're up in social economic status, the better the healthcare you're going to get. There are many ways, both financial and through social engineering, that the better off get better healthcare. And I do believe that used correctly, AI actually can be a leveler of these rather than a promoter of inequalities.
Yeah. Thank you, Zach. Another couple of questions that came through Slido. You made the point about AI being a potential great tool for empowering patients and the public, the example you gave there with Alex. You also talked about how, to some extent, clinical staff are already using AI and large language models in their practice. How do we get the balance right between, on the one hand, allowing people to start using these tools, and on the other hand, trying to regulate and understand where they're actually accurate and where they're not without being too heavy-handed?
So let's be clear. Patients, when they're really sick, they're not going to care about regulatory status, and they're going to do it now. They are doing it now. And I looked at studies. It's true that this is happening more in the United States than in England. It's happening in a majority of patients have actually used AI to actually ask questions. It's only a minority in the UK. But nonetheless, if we don't do the regulatory frameworks, patients are going to use it anyway. And that's going to happen now. And so it's not so much a matter of whether we regulate or not, it's how we regulate. And having patients as part of the discussions, which I heard earlier, is absolutely essential. And not just patients who are worried about privacy and about Big Brother looking over their shoulder. That's a very valid opinion. But I would urge you to include patients who are sick. Sick patients, I'm involved in something called the Undiagnosed Disease Network. And those patients want us to share their data with as many people as possible because they're in desperate straits. And there's the whole range in between. So I really think that seriously engaging with the need and the need that our patients feel. As doctors, we're not delivering the care that our patients want. And so we have to figure out what the true trade-offs are, as opposed to a purely academic perspective on a platonic ideal of medicine that does not exist.
Great. Thank you, Zach. And one more question before I wrap it up. I think you made a very well-made challenge, which was that we have to think about AI in the context of where the healthcare system is likely to be in the next 5 to 10 years in terms of staffing, in terms of patient expectation and demand. At the same time, and this is the question, because healthcare is such a complex system, but also because the development and evolution of AI is so hard to predict, where do we start to even think about what 5 years from now might look like to begin to have the right conversation now? Or is it indeed futile to try?
I don't think it's futile because here's the challenge for us. Medical school is not yet training our doctors how to use AI. But I can tell you that our young doctors are already using AI. And so I think the place to engage this is right up front in our training. We're training our doctors for the medicine that's going to be 5 years from now. And so I think that it's a great place to have those discussions. And I do think that there's also real opportunity in the entrepreneurial sense. There are going to be, whether we like it or not, companies that see how we're not delivering the care we need. And if we're not careful, they'll focus, in fact, on the richest segment of patients. But I think promoting entrepreneurial approaches, pilots, where you don't solve it for the whole NHS, but you say, we're going to create this pilot program where we can really instrument it and test it and see all the problems, is my strongest recommendation. We saw in the last 20 years that trying to do big implementations of the electronic health records all in one sweep were disastrous and incredibly wasteful of time and energy and with bad outcomes. So much better if we'd agreed on a focused set of pilots in the last 2-3 years where we could learn what we need to do. So my strong recommendation is invest in very comprehensive pilots. Even if they don't have it quite right, a lot of the important low-hanging fruit questions will emerge and will be addressed, and invite the public to have that discussion, and don't wait for these pilots to be over to engage the public.
Okay, great. Zach, thank you so much. That was a wonderful loop back to the beginning of our conversation and the priorities, particularly engaging with the public and focusing on the right things to learn. So again, thank you very much, and a warm applause. Thank you very much. Okay, with that, it's my pleasure to draw the evening or afternoon to a close. I hope when we meet again, which I think we're planning to do at the Health Foundation in a year's time or so, we will be able to answer or at least progress some of the questions that have been raised today, whether about the priorities in the NHS for AI, or indeed some of the questions and challenges Zach just raised for the next 5 years or so, and can discuss them again. We will be doing a lot of work here at the Health Foundation with partners and in collaboration to try and help answer some of those questions and generate the right evidence for that. Right, with that, if you've joined us online, we will share with you an event survey shortly. We really love your feedback. We'll do the same for you here in the room. Indeed, if you are in the room, please join us for some networking and a reception now just outside and up the stairs. If you're online, thank you very much for joining us. The whole event will be available to watch online in the next few days after that, and we hope to see you all again soon. Thank you very much.